So here's some pictures of atopic eczema. As I say, I'm just going to whiz through because I've got quite a lot of conditions to go through. But just to say that generally in school-age children, I suppose the perception is that of flexural eczema, the common sort of pattern in children. But it's really just to say that you can get all sorts of different patterns of eczema in children. This is sort of a more generalised, slightly follicular pattern, which has some flexural involvement, but isn't classically flexural. Get discoid eczema, sort of plaque forms. And teenagers, particularly if they've had atopic eczema as a child, can actually develop hand eczema, and this could well be a contact allergy. Darker skins, it's very important to realise that eczema is very different in darker skins, and often the child who has a darker skin is often not seen as having such severe eczema. But this little boy has eczema as bad as any of these sort of inflamed areas here, but often the eczema presents as a hypopigmented pattern. The other thing to remember is that there's often what's called a reverse flexural pattern, particularly in African, Afro-Caribbean skin, where you get sort of plaque form and the eczema sort of going from the flexure round to the elbow. It can often be misdiagnosed. And of course, every skin type can be exceedingly itchy. I sort of use pictures sometimes to explain things to the people I look after, and certainly children with eczema have very dry skin because there is an actual derangement in the skin barrier. This is something Margaret and I could talk about at length, but the basics are that if you have normal skin, it's like an evenly brand new cement wall with even corneocytes that are not letting irritants in or water out through the transepidermal water loss. So this is representing the stratum corneum. In eczema, you've got uneven corneocytes, skin cells, with gaps in between because you're missing the lipid laminae, which is the sort of cement in between the cells. The cells are kept swollen and tightly together by the natural moisturising factors, and therefore you've got gaps where irritants will easily come in and water will be lost out. So this is really the principle why emollients and moisturising the skin to actually put a seal of moisturiser over the skin, stop the water coming out from the skin and the irritants coming in is so important. And I say that as a point in school because really the only treatment that you need in school is the emollient to keep restoring the skin barrier. If the eczema is flaring, of course you need treatment, but generally steroids are used once or twice a day, which can easily be applied outside the school day. So there should never be any need for topical steroids to be brought into the school environment. But moisturisers, yes, every school-age child should have the opportunity of a private area and should have the support to be able to moisturise their skin if they get dry and itchy in the school day. Itch is very difficult to manage in eczema sometimes. It often is a vicious cycle, and the dry skin will always lead to itching. Itching will lead to scratching. Of course, the child who is very itchy with the eczema scratches a response to the itch. Sometimes scratch in the chronic times can also become a habit, and sometimes children, perhaps when they are concentrating hard at school, can concentrate with a little scratch going on at the same time. It almost becomes a little bit like a comfort blanket sometimes as well. Obviously, there are lots of trigger factors. They tend to be individual for everybody. But I think in school, one of the biggest trigger factors perhaps is the soap. Schools, like public places, use sort of quite harsh detergent-type, cheap liquid soaps. And again, the child of eczema, this could play havoc. Where at home they've been very careful, using soap substitutes, not using soaps. And of course, if they're doing artwork or, even getting muddy in the school playground, they might be encouraged to wash with soap at school. So no soap really for the child of eczema at school, and ideally they should be able to have a little pot of their moisturiser they use as their soap substitute. But again, I think that's slightly easier said than done, although it shouldn't be. Climate can make a difference, so sometimes playing outside in the playgrounds, classrooms can be very hot, so moving from hot to cold atmospheres again can trigger the eczema as well. The NICE guidelines for atopic eczema, have you all seen the NICE guidelines or heard of them? Yeah, they are fantastic guidelines, they really are. They give you so much information on eczema, a whole stepped management of programme, and they're really worth looking at, and they really have a lot of information. I won't go through all this assessment, but they, you know, if you have a child in school with eczema, taking through an assessment and asking all the relevant questions to actually assess how to help that child individually is very important. They recommend the step treatment plan, where, as you see, you have emollients every level of the severity step, and then you step up to the mild, moderate and more potent treatments there, and stepping up and down according to the physical severity. A lot of the learning to manage the flares, as I said, will be in the home environment, but I think the teachers in school being aware of when a child is flaring and you know, needs perhaps extra help at school will be useful. And of course, if they have got infection, they may well be on antibiotics, oral antibiotics, so they will need to be administered in a school environment. A little bit more about complete emollient therapy, which is using emollients for washing, showering and leave-on emollients as well throughout the day and the night. Applying frequently large quantities and in a sort of downwards stroking motion. I certainly work with the children in my clinic while they're sort of older aged nursery child, 3.5 to 4, and basically working with the parent and have been with the nursery teachers as well, using reward chart systems to actually get the child to actually apply their own emollient completely independently before they leave nursery and before they start school. So when they go to school, you know, they are able to apply it themselves, because there is a big problem about schools applying emollient for the child, but I feel that children with eczema need to understand that emollients are going to be part of their everyday hygiene routine, and I sometimes relate it to teeth cleaning or being toilet trained. You know, child learns to cope with their own toilet needs before school, would you hope, although I know that's not necessarily the case. And also, you know, they should be able to clean their teeth by 4, so they should be able to apply their moisturiser. The steroids are different. It might be the parents still applying those, and the letting go, as Margaret said, is... emollients, there's such a big range, and this is not exhaustive. There are quite a few that aren't there. That happens to be what I have in my cupboard. I don't have eczema as such, but I teach about eczema and I have a range, so they happen to be. But there's a big choice, and not everything suits all. I won't go into steroids, but again, thinking of the potencies, how much to use. Recognising infection is very important, and this is relevant for school, because children with eczema are certainly much more susceptible to Staph aureus infection, carry about 80% more staph on their skin as normal skin, so the likelihood of infection. And certainly, you know, if they're in a dry, dusty classroom and they're starting to scratch a lot, this could be a time when the infective cycle starts. Molluscum, I'm going to speak about molluscum a bit later on when I talk about other infections. But again, children with eczema are much more susceptible to molluscum as well. They tend to get molluscum much more severely. And really one of the worst infections for eczema is the viral infection from the herpes simplex virus, eczema herpeticum, which actually is classes as a dermatology emergency, where you get very, very painful blistered sore skin because the herpes virus actually superimposes on the eczema. So again, if you have a child who has a friend and they have a cold sore, it would be very important to say that that child with eczema could be susceptible to this, so you would try and avoid any sort of close contact at school, which, and certainly when we're thinking about teenagers, because we're thinking about teenagers as well, certainly with teenage romances in schools, there shouldn't be any kissing and cuddling if you know, a boyfriend has herpes and a girl has eczema, because that's, and certainly with the parents as well, it's very hard telling parents not to kiss their own children, but you know, this can be quite an emergency. So some implications for eczema in schools before I move on to some of the other conditions. Emollients are the basis of management, and they are a daily routine. And when I say a daily routine, depending on the choice and what's used, for some people they may need to use them several times a day. Indeed, people with eczema should always use moisturisers 2 or 3 times a day. So certainly emollients should be easily available at nursery, preschool and school. And this is a statement from NICE, from the Atopic Eczema Guidelines. So this is national guidance saying Emollient should be easily available at school. So if there is any issues with schools not wanting to have emollients in the school or not wanting to give children the privacy to reapply their emollients, you can quote NICE straight back at them, and they really won't have a leg to stand on. Children should be helped to avoid triggers at school. You think of Daniel and his radiator, and soap and heat probably are the two worst enemies. And obviously the National Eczema Society, which we've said. We did have an article written recently, which was written by a teacher who has eczema, a mother of a little boy with eczema, and a mother of an older child with eczema, which is available on the website. It's called Saved by the Bell, and it's a very nice article, and it has lots of tips for managing eczema in school, actually written by the people with eczema themselves and the parents, and from a teacher's perspective. So you should be able to access that on the website, which might be useful. So now moving on to skin infections. We've mentioned a little bit about infection in relation to eczema, but of course these are two very common skin infections seen in all school-age children. So can you recognise them? Do you know? Oopsie. What's this one? Sorry? Impetigo, well done. And you recognise that because it's quite dramatic, quite sudden, and you've got these yellow golden lesions because aureus means golden in Greek. That's where it comes from. And then this one is another fairly common one that can be quite alarming. Do you know what this is called? Slap cheek, or fifth disease. It's called fifth disease because it happens to be more common in the fifth decade, which of course is reception year 1 year. And really, this is the advice. Impetigo is highly contagious, and lesions are crusted and healed. So basically, the child should stay away from school until the lesions are crusted and healed, or 48 hours after oral antibiotics have commenced. With slap cheek, even though it's quite alarmist, and I know children are taken off school, there's actually no need to take off school because actually they're most infectious before the rash appears. So when they get their little red cheeks, which are just unsightly really and a bit strange, they look very rosy, don't they? There's nothing you can do. The infection will be there. It's a viral infection and a bacterial viral infection. Fungal skin conditions, well, of course, this is very common, particularly perhaps with sporty children who are swimmers. You know what this is? Yes, athlete's foot or tinea pedis, a dermatophyte infection. This is another fungal infection. You know what this is? This is pityriasis. Have you heard of pityriasis? Which is sort of a yeast-generated infection. And this is actually a tinea of the scalp. This is called a keryon. Do you know what this is? This is a bit more concerning because it's a harder infection to clear. This is tinea capitis. There is still, there have been in the past, and I think it's still a problem area in southeast London with tinea capitis. Does anyone work in southeast London and seen tinea capitis? And there were some prevalent studies done, certainly in the 90s, from King's about an epidemic of tinea capitis, particularly in Afro-Caribbean populations. So it can be quite a nasty fungal infection. So again, sort of advice for schools and implications. Tinea capitis does tend to be quite alarmist, and certainly the advice has changed in recent years. It used to be that if a child had tinea capitis, they did need to. It was advised that they should be off school because it's quite a highly contagious fungal infection. It tends to be more contagious in families because it's actually adults who are the carriers. So there is a theoretical risk of children passing on in school, but it tended to be passed on more with sort of sharing of hair braids and combs and close sort of head contact. So it tends to be more infectious within a family than at school. And the adults who are carriers don't get any symptoms. So the really key thing with tinea capitis is, if it develops in families, is that the whole family should be screened and treated. Children have to be treated with quite a potent oral antifungal called grisoflavin, and that's generally a once daily dose, so it won't have to be given at school. And certainly antifungal shampoos need to continue for a good sort of 4 to 6 months to try and get rid of the infection. With tinea pedis, again, if swimming is something that's done at school, the child should wear flip-flops in the changing room and not share towels, because dermatophyte infections and the tinnias definitely, they basically are andropopophil infections that like man as a host, so they really only survive on man as a host. Other fungal infections, and tinea capitis is one that also can be passed from human to animal, can be passed between human, animal, and other fungal infections are geophilic, so they come from the soil. But with tinea pedis is something where man likes the host, and it actually can multiply in warm, moist conditions. So that's why children who are swimmers quite often have athlete's foot. And of course, as you get older, if it's not treated, it can actually start to affect the nails, and fungal nail infections, which don't tend to occur in children but can occur starting from the teenage years, are very hard to treat. Pityriasis versicolor is no risk of transmission at all. It doesn't look very nice. It's sort of unsightly, pigmented skin, but there's absolutely... It's an infection that isn't easily transmitted. Again, it's just sort of one of those things and tends to be more of a yeast-type infection. Viral skin infections, well, again, this is your molluscum, the sort of pearly white areas that when... It's the only skin condition that you actually, if children do itch it, and I hate to say this as a dermatology nurse, it pains me, you don't necessarily need to say don't scratch, because actually if you do scratch and damage molluscum, they tend to go away. But the other thing is it can actually spread them further. They don't tend to be particularly itchy. They are, again, just a bit unsightly, and it's all... And molluscum, very like head lice, tend to worry the parents more than the child. I'll come on to head lice in a little while. Warts, plantar warts. Again, I think they can worry the parents more than the child in younger years, but certainly in older children, they can be very distressing, and certainly children can get teased. I was actually thinking of my own daughter, actually, who doesn't have eczema, but when I was doing this talk, I thought, gosh, I have had quite a lot of experience, because she actually, when she was 5, she had quite a lot of molluscum, as did most of her class. We've just managed to, after sort of 6 months, to get rid of her warts, which were very difficult and very unsightly, and she didn't like them at all, and they were on her hands. And she also had terrible head lice, which I managed to get rid of after about 6 months. Anyway, and this again is eczema herpeticum, and you can see the herpes virus sort of blistering and causing quite a lot of pain there. So again, children, sorry, I should say with, not wit warts, witty warts, although my daughters were, with warts and verruca should not be excluded from sport and swimming. I think that's quite important. Again, that used to be a myth. If a child had a verruca on their foot, they couldn't swim, and then they might not swim for a whole term. I am presuming that some children in schools do swim. I know not all schools do swimming, but hopefully children do get the opportunity to swim at schools. So really it's avoiding being bare feet, again sharing towels and trying to cover the verruca with plasters. I know you can get sort of verruca socks, can't you, as well? And perhaps I think for more widespread verruca they might be quite useful, but a simple covering I think should be fine. Molluscum is contagious, and some children will be more susceptible, particularly children with eczema. So spread is kind of inevitable, but generally not too bothered. I mean, if you took any average, particularly sort of, foundation, key stage 1 class, I'm sure you'd find quite a percentage of children with molluscum. And a lot of it's to do with immature immunity and building up immunity to, against these kind of infections. And as I say, herpes simplex, and maybe, there's good advice there for the teenagers as well, try and avoid. So we now come on to head lice, which I think causes more angst than anything, really. Do you find that? There is so much distress about it, and again, from personal experience, we get letters every 2 weeks, as a child with head lice in the school, start combing again, which is very important. But yes, it's a difficult problem. I think basically the advice, and this is from the Public Health Environmental Group, which is the 2012 guidelines update. It's quite a lengthy document, probably about 10-12 pages, but it's very good. It gives really good, clear advice. And this public health advice can actually swap and change as well, as you know, and I'm sure certainly as school nurses you're in a public health role, so you're probably very up to date with all this. But obviously chemical treatment should never be found unless a living, moving louse is found. And I think that's often the problem. A child starts to perhaps develop nits, which obviously aren't the live lice yet, and rather than combing through, it's often, straight to the chemical treatment, and that's obviously what causes the resistance. But certainly, there are the general recommended treatments there. I think sometimes you can do things that perhaps aren't chemically based. I actually got rid of my daughter's head lice eventually by suffocating them with hydromol, which was a thick, greasy emollient. I just smothered her head with it and left it overnight, and we suffocated them all because I just found it really difficult to manage, actually. And lots of combing, the combing with conditioner. But again, it's really hard. My daughter was 7 at the time and had quite long hair, and she used to hate me combing her hair. So I used to literally have to pin her down and comb it through all the time. But the combing became something that we just had to keep doing, every day to start with, and then every 2 days, and then every week. But a lot of it is, the combing and repellents aren't recommended. But I think there's a lot of feeling that these lice literally are jumping around the classroom. They jump and leap from one head to another, and they literally don't. And that's why younger children get them, because at playtime they tend to have close head contact, and they do move transmission between heads. Yes, and it's very rare, obviously, for adults to catch head lice from their children, although it's not unknown. But scabies does tend to be something that runs in families. Certainly, the question in dermatology in clinic, if a child or adult comes in and they're very, very itchy and they don't particularly have a history of atopic eczema, the first question always is anyone else in the family itching? And if it is a family problem and everybody's itching, you're almost certain, 100% certain it's scabies. And also scabies are another little mite which actually gets under the skin. They sort of burrow. There's a sort of crust where they've entered, and they sort of burrow along. They cause absolute intense itching. It tends to be much worse, the sort of rash and itching and severity in the very young, so in the babies and also in the elderly. In fact, we're not talking about older people, but the older people can actually develop a very resistant form of scabies called Norwegian scabies, just because it was first discovered in Norway, no other reason. But you do get these sort of areas here. The life cycle of the scabies mite is that they copulate in a burrow. They lay 40 to 50 eggs, so that's why the infection becomes so rife. And the larvae emerge from the eggs, transform into nymphs, and then they live for about 4 to 6 weeks. So it's a sort of absolute cycle. But they breed like crazy. So the current guidelines, again, looking at Health Protection Agency guidelines, this time 2010, a good source of information because they do sometimes circulate the insecticides that are used for these, and it's applying to the whole body. Now, the problem is if you have an outbreak of scabies in school, which I've seen it in nursing homes rather than a school situation in my practice. It's really, really important you treat everybody at once. So certainly I can remember going to a nursing home one evening and treating every resident, every member of staff, and every member of their immediate family. It was an absolute production line, and that's the only way, really, to make sure that you eliminate that particular outbreak. So, and if it is certainly with that outbreak, the public health department in Oxford were involved with me, and I worked with a public health nurse because it was a nursing home that had developed a very nasty sort of outbreak of scabies. So I haven't really heard an experience of somebody having an absolute outbreak in the school. I think it would probably be more a family situation, but it would just be you knowing as a school nurse that scabies was particularly in that family, and that child had to be treated at the same time as other members of the family. So it's always direct person-to-person contact. They really can't jump, these licensed scabies, and all close contacts must be treated, even if they're asymptomatic, even if they're not itchy with scabies in their family. The interesting thing with scabies is the itching does persist for 3 weeks after successful treatment for scabies. So the itching doesn't necessarily go away. And as I say, only treat live lice, and the wet conditioner combing is really key. And, it can be very emotive head lice, but prevention absolutely is the responsibility of the parents. It really is the parents who've got to put the hours into the wet combing and the treatment. It's not really the responsibility of the school, although the school have a responsibility to inform. So psoriasis. Psoriasis is a complex condition. We now know, when I first came into dermatology, it used to be thought of a skin condition, but we now know that actually it's a complex immune condition that actually links to many sort of inflammatory processes and other inflammatory diseases, such as arthritis, which actually we have known for a while, but now being linked to Crohn's disease, even peripheral vascular disease and heart disease. So for the very severe end, it can be quite a multi-organ disease now. It's very common, and there are two ages of peaks, and teenage years is one area of peak. Childhood psoriasis is fairly uncommon, a lower prevalence, but there are different types of psoriasis, and children, particularly if they have recurrent tonsillitis and streptococcal throats, they can develop a raindrop pattern of psoriasis called guttate psoriasis, which sometimes can just be a one-off, something that just comes and goes with the infection, or perhaps comes and goes with recurrent infections. But particularly if there's a family history, because again, it's an inherited condition, it can be a marker for the child then developing chronic plaque psoriasis as a teenager. And certainly with secondary school children developing psoriasis, particularly at the age when they're self-conscious, the body image, wanting to be part of the crowd, it can be absolutely devastating. I've nursed quite a few 14, 15-year-olds, and it's really, changed their personality, been quite devastating, and taking them a while to cope and get through those years of accepting having a chronic skin disease. There's some sort of pictures of childhood psoriasis. This is the sort of guttate form, which is the sort of small raindrop form. As I say, that can move into this sort of more chronic plaque form of psoriasis, which you can see here. Common areas, elbows, knees, smaller back, and also the scalp. The scalp is difficult because it's an area that's seen. It can also scale and be quite unsightly. And I think children with eczema and psoriasis can equally be subjected to teasing, but a lot of it is the appearance of the skin, and perhaps other children thinking that they're dirty or unclean, or they're scaly, or they, the very sad stories, they don't want to hold their hands, because again, this sort of prevailing myth that skin diseases are very infectious is not true at all, but certainly for psoriasis and eczema. But unfortunately, it still seems to be inbuilt in an attitudinal thing sometimes. There's lots to say about management, but I'm not going to say much, because again, the topical treatments of psoriasis will not need to be used in the school environment, but there are various treatments, and again, rather like eczema and the organisation and the mindset, it's about keeping this treatment regime at home, because treatments again will be used once or twice a day. And again, topical treatment regimes for psoriasis can be quite complicated. They are very individual, and sometimes it's trial and tribulation. But certainly the emollient therapy is as important as psoriasis as eczema. In some ways, particularly because you haven't quite got the restoration of the skin barrier, but you've got very sore, dry, cracked, heaped up areas, and you need to address the scaling and also try and reduce pain by those cracked areas actually fissuring and becoming uncomfortable. So again, children can join in all activities, including sport, particularly swimming. I'm not obsessed by swimming. I did used to be a swimmer, but I'm not. But a lot of people with psoriasis think they can't swim, and indeed public swimming baths still turn people away who appear with psoriasis. And it can cause pain with cracking and itching, and that's the other thing. Psoriasis is an itchy skin condition, perhaps not as intensely itchy as eczema sometimes, but it can be itchy. It's important to inform your child's teacher, obviously, about the condition, and obviously the teachers are a great source with circle time in classrooms of talking to children about maybe skin conditions or what children are going through, and helping other members of the class understand. And obviously treatment routines need to fit around school and emollients at school. The Psoriasis Association is another wonderful support group, and they've just actually produced two great new websites. One is a general website, and they've had a complete revamp, a new logo. But they have developed a fantastic website for teenagers, and it's so nice for teenagers to be given that extra support in a format that they can relate to. I should say the Eczema Society also have a teenage booklet on eczema as well. But the new psoriasis teenage website, Sorrow Teen, is really nice, and I think it gives lots of tips. It talks about things very pertinent to teenagers, indeed exam stress, how to manage exam stress with your psoriasis, and how to not be anxious, how to deal with questions your friends might ask you about your skin. So I would highly recommend that, really. It's helpful. And moving to acne, last but definitely not least, I feel very passionate that acne needs to be addressed as a much more seriously, because really in this day and age, and certainly really for the last 15-20 years, there should be absolutely no need for anyone who has acne as a teenager to actually be scarred for life. And unfortunately, you're still seeing teenagers who aren't treated adequately with their acne and are ending up with scars that they carry through their adult life. In fact, managing and treating acne is incredibly satisfying, because it is an absolute stepwise protocol approach. You start with one base of topical treatments. And again, I haven't got time to go into all the treatments today. And you move through the programme, trying every treatment for at least 3 months. That's the key thing. You can't just move from one treatment to another, and you need to surround it with other good general skincare. But there are so many myths about acne, which is a disease that firstly appears in puberty, because this is when the sebaceous glands actually turn on and become active. You get sebaceous gland activity in babies up to sort of 6 months, because the sebum activity is passed placentally from the mother to the baby, and that's why you can the sebaceous glands then tend to be immature, and you get an immaturity of sebaceous glands, but then they tend to turn off at 6 months. And then children, the sebaceous glands, you don't have any greasy producing glands as a child until you get to puberty. And then the androgen hormone then turns them on and starts to produce testosterone and estrogen. But what you get is you get a blockage of the sebaceous glands, because they're literally overproducing. And again, some people are more genetically susceptible to more severe acne. And you get colonization with an anaerobe bacteria, Propyron bacterium acnes, which obstructs the phytosebaceous cyst, causing papules, pimples, nodules, with this increased production in the skin. So at the mildest end, you get comedones, which are whiteheads or blackheads. And you do know the black in the blackhead isn't dirt, it's melanin. It's just the reaction of the air to the open comedone. And so that's sort of the start of the sebaceous gland sort of blocking, really. The other important point is that sometimes teenagers can have quite mild facial acne, and you think, well, why are they so worried about it? And they may not have told you, but it's really important to examine the chest and the back, because sometimes a teenager can have mild facial acne, but they can have much more severe acne on their back or their chest, which they're continually covering and not actually telling you about. So always examine the whole area susceptible to acne, which is the face, chest and back. More moderate presentation, you get more sort of pustules. Again, teenagers with darker skin can be much more prone to keloid scarring, which is quite a nasty scarring, a very sort of heaped up scar, which again is very difficult to treat. So again, all skin types are susceptible to degrees of scarring, and some a bit more than others. And then in severe acne, you can see how severe this is. You see, unless with a small percentage who are perhaps genetically disposed to very severe acne, teenagers should never get to this stage. The treatment should always be used in the mild and moderate to stop this, because unfortunately, these are some of the treatments now. I'll just move on and come back. Acne scarring and this is acne scarring in all different types of skin types, should actually be prevented. It really shouldn't happen nowadays with the right treatment. So the treatments are the mildest form and the whitehead, blackhead stage, certainly antiseptic washes and benzoyl peroxide type solutions. You do need to start with a mild benzoyl peroxide and work up because it can be irritating and it can be drying. In acne, you kind of want a bit of drying because the skin's very greasy and you want to turn off the grease glands. And then you can have single agents prescribed, but really combination treatment is a preferred regime where you have benzoyl peroxide with topical antibiotics, or if it's a lot of whiteheads and blackheads, you can get a retinoid combined with an antibiotic as well. And for girls, certainly with moderate acne, even though again it's a controversial issue, always consider a sort of progesterone contraception, which is anti-androgens such as Dianet or Yasmin, because that can also help turn off those circulating hormones and then move to oral antibiotics. Advising on washing and general skincare is important. A lot of teenagers with acne overwash and overscrub, so they need gentle washing, and generally with sort of gentle antiseptic washes or benzoyl peroxide type washes. Always observe the 3-month rule for any treatment from any spectrum because you need 3 months to get it to work. Treat the entire face, chest and back. This is a really common error. Most people have acne treatment and they dab it on the spot. The acne area is the whole sebaceous gland area, and that's the way to prevent new spots coming. So treat the whole area, and it's amazing how many people don't know that very simple fact. People want to squeeze their spots. There used to be a wonderful acne support group, which sadly doesn't exist anymore. But Alison, who ran the group, had this wonderful traffic light system, which I quite like, which is if the spot's red, stop, do not squeeze. If it's amber, don't squeeze it. So if it's sort of pussy, but just stretch it. And if the pus really is there and is very tight, it will just pop out, but don't actually squeeze it because that's another way to scar. And if it's green, well, there's something else going on, so go to the doctor. But it is curable. That's the exciting thing about acne. And like psoriasis and eczema, it is curable. Step up the treatment and early referral and do prevent scarring. There's more I could say about oral antibiotics, but I'm fast running out of time. And that's the other thing, making sure they're taken at the right time of the day, with food, without food. Certainly the once daily antibiotics now are much easier as well. And I won't talk about isotretinoin because I've run out of time. But the implications of schools are really support as a school nurse, try and dispel all those myths. There are lots of myths about acne. It's not caused by junk diet, greasy hair, poor hygiene. Makeup. Girls do wear makeup at school as teenagers. Perhaps they shouldn't. Perhaps they break school rules, or perhaps they're allowed to wear makeup. I think they are actually allowed to wear makeup in a lot of secondary schools now. So if they do wear it, to advise them to be water-based, oil-free makeup, which is labelled as non-comedogenic. And also, very simple, but tell them, for goodness sake, remove your makeup well at night. You don't go to bed with your makeup on. Actually, that goes for eczema as well, I have to say. And isotretinoin, this would be another talk in itself. It's a fantastic drug, but it does have quite a lot of side effects. And I think the key to isotretinoin is that if somebody has moderate eczema and they're starting to scar, in about 80% of people it will actually cure their acne totally, leave them with really quite lovely skin, but the actual counselling before they take this drug is so important because there are a battery of side effects. Girls have to have 2 forms of contraception, there's pregnancy testing because it's tetragenic, there's lots of ethical issues. But some of the other side effects that aren't perhaps quite discussed are a lot of children who are very sporty. It will actually affect their sports life. It gives them aching muscles and a low-grade flu. We have a girl at the moment in Bicester. She's a lovely girl, very distressed by her acne. She does want to start isotretinoin. She's read about all the side effects. The problem is she's a county netball player. She's in the national rowing championships in the summer at school. And there's another sport she does, and she knows that if she'd taken it in March when we saw her, it would have destroyed her sporting summer. So what she's going to do is she's going to start taking it at the beginning of July. So she's got 2 months into the school holidays before she starts school again, and then hopefully she'll adapt to it. So I won't talk about the controversy with it, but I think a lot of the controversy is because people aren't well enough prepared for and monitored, and the monitoring is key.